18-year-old female patient, Deborah, is brought to the emergency unit by her mother with a history of syncope and generalized body twitching or jerking movements. The history is that Deborah was in her bedroom when her mother heard a very loud bang, just as if someone had dropped on the floor or they banged against the furniture. When she got in, Deborah was there lying on the floor in a pool of blood with a laceration on her forehead, and the mirror and her dressing table were stained with blood as well. Next to her was her cell phone, showing that she has been taking lots of selfies. And in the process, Deborah continued to have these abnormal jerking movements. What could be the reason for that? Hi, you are watching ED Files, and I am Dr. Thabo Mafa. In an emergency unit, every second counts. A patient who presents with a seizure can easily have neurological outcomes which are not desirable, and they can even lose life if not treated promptly. Could Deborah be having a seizure? Or could it be just an act of attention or just merely a syncope? Let us zoom closely into her case and dissect every single aspect of it. What is a seizure? It is a sudden and abnormal neurological firing in the brain that could result in abnormal body movements such as twitching or jerking. And often it could result in an altered level of consciousness, such as confusion after the seizure. And in contrast, what is epilepsy? It is a recurrence of those seizures. And in this case, most of the time, these ones are unprovoked. Taking history about this 18-year-old female patient, Deborah, what are the most important aspects you need to know about? Firstly, you need to check if this seizure was witnessed by someone. How long did it take before it stopped? And was it of first onset, or even the patient is epileptic? How frequent are these seizures? You also need to ask about the precipitating factors. What triggers these episodes? And lastly, but not least, you need to know if there is associated level of consciousness, or is there any confusion after the patient has woken up? Was there any tongue biting? Did the patient have urinary incontinence after or during the seizure? What findings did we have when we examined Deborah? Her blood pressure, temperature, heart rate, and sugar were all within normal limits. However, her level of consciousness was about 14 out of 15. She had a deep cut or laceration on her forehead. She also had tongue biting and urinary incontinence. However, all other systems on examination were normal. What are the types of epileptic seizures a patient may present with, or what is the classification? A patient could have focal onset seizures or generalized onset seizures. And what are these? A focal onset seizure can either be simple or complex. A simple one, the patient would have a preserved loss of consciousness during a seizure, whereas in the complex one, there is loss of consciousness which is accompanied by confusion, and this we call a post-ictal confusion. Other features would be a patient would have an aura before the seizure happens, and also they could have a change in behavior or an arrest in behavior, whereby the patient would just be staring at something that no one else is paying attention to. And they could have abnormal movements such as chewing and also lip smacking. What about generalized onset seizures? We've got 6 major categories, but let us focus on 2, which I feel these are the most important ones. You can have absent seizures. In this case, the patient doesn't have an aura. There is no loss of consciousness, and there is no confusion after the seizure. One feature you would notice about these patients is they would have repeated blinking in the process of seizuring. And also, it can be triggered or precipitated by photic stimulation, and that is flashing lights. Whereas in the generalized or tonic-clonic seizures, also known as grand mal seizures, these patients would go into a state of post-ictal confusion after the seizure, and they would have generalized jerking movements. One other point I'd like to make clear is resolution of recurring seizures by means of medication is not diagnostic of epilepsy, even though it could be suggestive of it. Let us also talk about the differential diagnosis or possible diagnosis one could think of, especially when you see a patient who comes to hospital for the first time with a seizure. One possibility could be that a patient could be having a stroke. Secondly, it could be a migraine headache. And in children, it could have been a febrile convulsion. Other things could be low sugar levels, and the list goes on and on. How do we then investigate this condition? There is Debuho. We need to know exactly what the problem is. We need to do bloods. We have to do prolactin levels. These will tell you if this is an epileptic or a non-epileptic seizure. And in a patient who has had generalized tonic-clonic seizures like jerking or twitching of the whole body muscles, in most cases this would be 3 to 4-fold more than the acceptable limit. You also have to do infection markers, inflammation markers. Do your sugar levels also. Do your calcium, magnesium, and phosphate. And for a patient who is known to be epileptic and they are on a drug like Epilim or Keppra, you need to do the levels just to make sure that this patient is taking adequate dosage. And also, you can do some imaging studies as well. You have to do a CT scan of the brain, or you could do MRI scan of the brain. And last but not least, which is one of the most diagnostic investigations you should do in a patient with seizures, is an EEG. How do we then treat a patient with a seizure? There comes Debuho into the emergency unit. If it ever happens that this patient starts having a fit in the emergency unit, make sure you make them lie on a lateral side so that they do not aspirate into their lungs in the process of feeding. You also have to make sure that the scene around them is safe. Remove all the hazards so that the patient doesn't get hurt in the process of feeding. You also need to give them supplemental oxygen to assist the brain to have enough oxygen. And you should also give them medication to abort the seizure, like Valium or Rivotril or Domicam. Do not forget to give them a loading dose of an anti-epileptic, such as Epilim or Epineutin. Post-admission, make sure that you put these patients on long-acting drugs, such as Epilim or Keppra, depending on your choice of treatment. Do not forget to counsel the patient and also the family about this condition. In counseling the patient and their family, we also have to discuss activity modification and restrictions. And for a patient who is not well controlled yet on treatment, they need to avoid these things, such as driving, swimming, or using power tools such as grinders. They also need to avoid ascending heights. And one of the things they need to try and avoid as much as possible are flashing lights, such as cameras and video games or movies that are violent or flashing in nature. What was the outcome on Deboho's case? An 18-year-old female patient. She had syncope and seizure at home, and these were witnessed by her mother. There is evidence that she was busy taking selfies using a phone, and most likely there were flashing lights involved in the process of doing that. And even though this was her first episode of having a seizure, chances are that this was the triggering factor in this case. Bloods which were taken show that the prolactin levels were very high, more than 3 to 4-fold higher than normal. And this would suggest that the jerking body movements that she had are most likely generalized tonic-clonic seizures. The CT scan and MRI scans were normal. Her EEG suggested abnormal neurological activity. Looking at these findings and the history that we have, even though there is no recurrence as yet, we do suspect that Deboho might be an epileptic patient. So in conclusion, recognition of the signs and symptoms of epilepsy and commencement of treatment as soon as possible can save a patient's life. And thank you for watching.